The skin is the largest organ of the body and is made of the epidermis, the dermis, and the hypodermis. Burns result from exposure of skin cells to an overwhelming amount of energy in the form of heat, causing cellular necrosis. The degree of injury depends on the temperature, the duration of exposure, and the baseline structural integrity of the skin, which means younger children and elderly individuals are at a higher risk of injury because their skin is relatively weaker. Okay, burns can be classified based on the cause, or by the depth of injury which corresponds to the severity of the burn. Burns are most commonly thermal, which can result from scalds, such as hot water, or flames, such as from house fires. Less commonly, burns can be electrical, like from exposure to lightning strike or high voltage electrical current, or from exposure to chemical substances, which can be acidic or alkaline. Based on depth, burns can be first, second, or third degree. First-degree burns are also called superficial burns and involve the epidermis only. A prime example would be a simple sunburn from a day at the beach, which appears red with no blisters. Second-degree burns are further subclassified into superficial partial thickness burns, which involve the epidermis and the superficial dermis, and deep partial thickness burns, which involve the epidermis and the deep dermis. Superficial partial thickness burns appear red and are often blistered, whereas deep partial thickness burns appear red or white with no blisters. Third-degree burns are full thickness burns, extending through and destroying the entire dermis. These appear leather-like with a charred appearance and tense feel. Usually, third-degree burns are surrounded by a rim of second-degree burns. Fourth-degree burns extend beyond the dermis, destroying fascia, muscle, or bone. Because third and fourth degree burns destroy the entire skin, they destroy the skin nerve endings, and therefore can feel relatively painless. Due to their strength and velocity, electrical burns have an entrance and an exit wound, similar to a gunshot, but aside from that, the skin actually looks fine. However, internally, the muscles are injured, and even the heart can be severely damaged, so don't let normal skin fool you. Sadly, in children, specific burn patterns raise suspicions for physical abuse. These include burns with a sharply demarcated edge, smaller circular burns matching a cigarette tip, or burns in the perineal region matching a pattern that could only be explained if the child was dipped into scalding water. Management of burns begins at the scene. First, remove the individual from the source, making sure you don't expose yourself to electrical currents or chemicals. Additionally, remove all clothing, accessories, or jewelry from the individual, because these might be contributing to the injury. On the way to the hospital, cool the injured areas with room temperature water. It may be intuitive to use ice or iced water, but this should be avoided because it can worsen the injury. At the emergency department, management starts with the ABCs, that is, airway, breathing, and circulation. Using a fiber optic or direct laryngoscope, look for edema and obstruction of the airway. The decision to intubate is based on the presence of oropharyngeal swelling, stridor, and respiratory distress causing hypoxemia. But sometimes it's more subtle. Clinical signs like hoarseness of voice, facial burns, drooling, soot in the airway, or even singed nasal or facial hairs should encourage you to secure the airway prophylactically, even if the airway isn't swollen yet, or they're not in obvious respiratory distress. Sometimes it's too late and the airway has closed, and in that case, a surgical cricothyroidotomy is performed. In other words, if the main airway door is closed, you better break in through the window. Also, if exposure to carbon monoxide is a concern, like in the setting of a closed house fire, 100% oxygen is provided using a non-rebreather mask, and carboxyhemoglobin levels are measured. Alright, so burns cause a tremendous amount of fluid loss, but it's not as obvious as the fluid loss seen in diarrhea, vomiting, or bleeding. Burns increase capillary permeability, causing a tremendous amount of fluid to shift from the plasma to the interstitial space, which is called third spacing. To replace the loss, place 2 large-bore intravenous lines on an unburnt area of the skin. The amount of fluid to give depends on the total body surface area affected. Importantly, first-degree burns are not included in the calculation. To measure this, the rule of nines is used in adults. This method divides the body into 11 areas, each equal to 9%. The head is 9, each arm is 9, each leg is 18, that's 9 for the anterior aspect and 9 for the posterior aspect. The chest, abdomen, upper back, and lower back each represent 9%. 9 times 11 is 99, so that last 1% is the perineum. Sometimes the burn areas are patchy and it can be difficult to ascertain a percentage. To tackle this issue, the palm can be used to estimate, as the palm approximates 1% of a person's total body surface area. But because children have larger heads and smaller extremities, the rule of nines can't be applied to them. Instead, the more complex Lund and Browder chart is used, which takes into account the child's age. This chart can also be applied to adults. Alright, so once you've got the percentage, it's inserted into the Parkland formula, which calculates how much intravenous Ringer's lactate the individual should receive. Ringer's lactate is used because its composition is closest to the extracellular fluid. In the first 24 hours, the amount of Ringer's lactate to give in milliliters is equal to 4 multiplied by the weight in kilograms, multiplied by the percentage of the total body surface area involved. Half the number you get is given in the first 8 hours, and the other half is given over the next 16 hours. Alright, so the adequacy of fluid resuscitation is determined by inserting a Foley catheter and measuring the urine output hourly. In adults, 0.5 milliliters per kilogram per hour is considered adequate, whereas in children, 1 milliliter per kilogram per hour is adequate. The idea behind this strict fluid regimen is Jackson's burn model, which states that a burn injury is divided into 3 zones: a central zone of coagulation, which is dead and unsalvageable, a middle zone of stasis, and an outer zone of hyperemia. Adequate fluid resuscitation can potentially save the zones of stasis and hyperemia from irreversible injury. Under or over resuscitation can result in more tissue injury. Also, under resuscitation may cause acute kidney injury, while over resuscitation can worsen compartment syndrome or cause pulmonary edema. Tetanus toxoid should be given if the individual had not received it in the past 5 years. Also, tetanus immunoglobulin is added if they haven't received the primary series during childhood. In addition to fluid resuscitation, individuals with electrical burns should be placed on a continuous cardiac monitor because they might have cardiac arrhythmias. Electrical burns and burns that damage muscle tissue can cause rhabdomyolysis, which releases myoglobin into circulation. Myoglobin is toxic to the renal tubular epithelial cells, causing acute tubular necrosis. In addition to fluids, alkalization of the urine with the osmotic diuretic mannitol is recommended. Finally, extensive tissue necrosis releases potassium, causing hyperkalemia. Okay, now full-thickness burns appear as a leathery necrotic eschar. If that eschar circumferentially covers and pressures the neck, chest, or an extremity, it can impair perfusion, and this is called compartment syndrome. Also, an eschar around the neck can compress the trachea, and an eschar around the chest can impair breathing mechanics. To prevent tissue necrosis and hypoventilation, an escharotomy is performed. This involves making an incision through the eschar, relieving the pressure. Anesthesia is not usually needed because eschars are usually painless, since all the nerve endings in the dermis have been destroyed. A crucial aspect of burn management is analgesia. In minor burns, acetaminophen or non-steroidal anti-inflammatory drugs can be given. However, in more severe burns, IV opioids like morphine can help, especially if they're given early on. However, a challenging balance should be maintained because opioids can cause hypotension and respiratory depressions, side effects that we don't want in burns. Additionally, sedation with benzodiazepines or ketamine can be initiated to ease taking care of the wounds. Because burns increase the risk of stress peptic ulcers, or curling ulcers, intravenous proton pump inhibitors are given. The risk of venous thromboembolism, such as deep venous thrombosis or pulmonary embolism, is also increased in the setting of burns, and therefore, prophylaxis is instituted using unfractionated or low molecular weight heparin. Burns cause a hypermetabolic state, and individuals often can't feed themselves. Therefore, nutritional support is important. Enteral feeding using a nasogastric tube is preferred, but if they can't tolerate it, total parenteral nutrition, or TPN, is required. Next is local wound management. The skin is the most important barrier to infection, so if that barrier is damaged, the skin needs help preventing infection and augmenting healing. The wound should be cleaned with soap and water or sterile saline. Povidone iodine solutions, on the other hand, have been shown to delay wound healing and should be avoided. Acidic chemical burns should be irrigated continuously with water only for 20 to 30 minutes, and alkaline burns should be irrigated for hours, since they're far worse. It's actually not a good idea to neutralize an acid with a base, and vice versa. In fact, it's contraindicated, because this results in the release of thermic energy, which further damages the tissue. Okay, so any eschar or necrotic tissue should be debrided, because dead tissue serves as a habitable environment for bacteria. Debridement is done in a tangential method, meaning that thin layers of the necrotic tissue should be removed until there's uniform capillary bleeding throughout the wound. This indicates that you've reached viable tissue. An important aspect of preventing infection is giving antibiotics. But because blood flow is often compromised at the necrotic burn area, systemic antibiotics might not adequately reach it. Therefore, topical antibiotics are usually preferred, with a large number of options to choose from. Silver sulfadiazine covers most gram-positive and gram-negative bacterial organisms, as well as fungi, and its application is not painful. Its downside, however, is that it doesn't cover Pseudomonas aeruginosa, which is the most common cause of sepsis from burns, and it's not conducive to wound healing. Mafenide acetate covers Pseudomonas, but it's painful to apply. Silver nitrate is a good option for individuals with sulfa allergies, who cannot be given silver sulfadiazine. However, it leaves a blackish stain, making it difficult to assess the wound. If a wound infection is suspected, a tissue biopsy is obtained, and topical as well as systemic antibiotics are tailored to the offending organism. Sterile dressings should be applied daily, which help in wound healing. Alright, as a quick recap, burns can be categorized by cause and include thermal, chemical, and electrical burns, or by depth and include first, second, third, and fourth degree burns. Evaluation begins at the scene. Management also begins at the scene and includes removing the individual from the source and applying room temperature water to the affected areas. Analgesia should be initiated as soon as possible. In the emergency department, evaluation begins with the ABCs: airway, breathing, and circulation. Early endotracheal intubation is indicated if the individual has any of oropharyngeal swelling, stridor, respiratory distress causing hypoxemia, hoarseness of the voice, facial burns, drooling, soot in the airway, or singed nasal or facial hairs. When carbon monoxide poisoning is a concern, 100% oxygen is provided, and carboxyhemoglobin levels are measured. 2 large-bore intravenous lines are inserted to initiate intravenous Ringer's lactate. Using the rule of nines, or the Lund-Browder chart, estimate the total body surface area affected, and insert it into the Parkland's formula to determine the amount of fluid in milliliters to give in the first 24 hours. This is equal to 4 multiplied by the weight in kilograms multiplied by the total body surface area. Half is given in the first 8 hours, and the other half is given in the next 16 hours. Urine output should be monitored to make sure you're not over or under resuscitating the individual. Additional therapeutic measures include providing analgesia, the tetanus toxoid vaccine, initiating stress ulcer and venous thromboembolism prophylaxis, and inserting a nasogastric tube for enteral feeding. If the necrotic eschar is causing compartment syndrome, an escherectomy is performed. Burn wounds are cleaned, irrigated, and thoroughly debrided. Topical antibiotics are often indicated to prevent infection, and options include silver sulfadiazine, mafenide acetate, silver nitrate, and many more.
Burns are injuries caused by heat, cold, friction, radiation, electricity, or chemical exposure. When significant heat is applied to the skin, either in the form of a hot liquid, solid object, or flame, this thermal energy can result in irreversible tissue destruction. Extensive tissue destruction, especially in burns larger than 40% of the total body surface area, or TBSA, can cause fluid loss and with it hypovolemic shock. Burns are classified based on the depth of injury into first, second, third, and fourth degree burns, as well as burns accompanied by smoke inhalation. When evaluating a patient with burns, your first step should be an ABCDE assessment to see if the patient is unstable or stable. If the patient is unstable, first stabilize their airway, breathing, and circulation. This means that you may need to intubate the patient, obtain IV access, and administer fluids before continuing with your assessment. Now let's move on to the stable patients. If your patient is stable, start with a focused history and physical examination. History reveals thermal injury and can identify the mechanism of injury, such as hot liquids, flames, or grease. The physical exam will vary depending on the depth of the burn. Some burns might be accompanied by smoke inhalation, so let's talk about that. History might reveal delayed extrication from a fire in an enclosed space. On physical examination, your patient may have facial burns, singed facial hair, wheezing, or stridor. They may also cough up carbonaceous material or soot. Once you suspect inhalation injury, you should obtain labs, including an ABG and carboxyhemoglobin level. Findings may include decreased PaO2 and oxygen saturation. However, ABG might be completely normal initially. When it comes to carboxyhemoglobin, in non-smokers with inhalation injury, it might increase over 3%. However, in smokers, these levels might be greater than 10% since they are chronically exposed to carbon monoxide from tobacco smoke. Next, order a chest X-ray. The initial chest X-ray can be normal. However, it is important to establish a baseline evaluation of the lungs. If your patient is intubated, you should also perform a bronchoscopy, which may show carbonaceous deposits, edema, and erythema throughout the airway. Other findings include bronchuria, or copious sputum, and bronchial obstruction. Mucosal sloughing typically appears later as bronchial inflammation worsens due to chemical byproducts in the inhaled smoke. Based on all these findings, you can diagnose inhalation injury. The next step is to start inpatient management. This includes administering high-flow oxygen to maintain oxygen saturations above 90%. If the patient develops drooling, wheezing, or stridor, or is unable to maintain oxygen saturations higher than 90%, they should be intubated if they aren't already. In an intubated patient, you can also perform serial bronchoscopies to monitor the progression of the injury and wash out any carbonaceous material within the lungs. Burns are classified based on the depth of injury into first, second, third, and fourth degree burns. Let's switch gears and talk about first degree burns, also known as superficial because they involve only the epidermis. To remember first degree burns, just imagine a sunburn. So, on physical exam, the skin is soft, it blanches when pressure is applied, and is typically painful. If you see this, then you are dealing with a first degree burn. Once you diagnose a first-degree burn, you can treat them on an outpatient basis. Management includes wound care, like cleaning the burn with cool tap water and mild soap and applying topical analgesia, such as aloe vera, if needed. If they require additional pain management, acetaminophen is usually sufficient. Now, let's move on to second-degree burns, also called partial thickness burns since they extend into the dermis. On a physical exam, the involved skin is usually warm, soft, and erythematous, and there might be pain to palpation. The skin may blanch when pressure is applied, however, blistering is often present. Deep second-degree wounds are less painful since some nerve endings have been damaged. They also blanch less than superficial ones. Alright, let's switch gears and talk about third-degree burns. Third-degree burns, also called full-thickness burns, are deeper and extend to the subcutaneous fat. Patients usually report little or no pain due to significant nerve damage. On physical exam, the skin may appear white, brown, or charred, feel firm or leathery, and doesn't blanch with pressure. Lastly, let's talk about the most severe burn category, 4th-degree burns. In 4th-degree burns, there is little or no pain due to extensive tissue necrosis. On exam, the skin appears charred and the burn extends down to the muscle, tendon, or bone. Once you diagnose the 2nd, 3rd, and 4th-degree burn, calculate the TBSA to determine the treatment. The first method to calculate TBSA is the rule of nines, which assigns specific percentages to different body surfaces. In adults, the head represents 9%, the anterior chest and abdomen are 18%, the back is 18%, and the perineum is 1%. Each arm is 9%, while each leg is 18%. Another method is the Palmer method, which involves estimating the affected area based on the size of the patient's palm, which represents 0.5% of their BSA, or their hand, which represents 1% of their BSA. The last method, called the Lund and Browder chart, is the most accurate but lengthy method. Here you mark an outline of the burn on printed body diagrams, calculate the affected area in each region, and add all the areas to obtain the TBSA. Once you determine the TBSA for your patient, you should decide whether they meet the criteria for inpatient management and even transfer to a dedicated burn center. Comorbidities or immunocompromised state, multiple trauma, any partial thickness burn greater than 10% TBSA, any full thickness burn, any burns to the face, hands, perineum, feet, or over joints, and any circumferential burns are criteria for inpatient burn treatment. If the patient doesn't meet these criteria, you can start outpatient management. This is the case with partial thickness burns that are less than 10% TBSA. Outpatient management includes daily dressing changes and the application of topical antimicrobial agents such as bacitracin or silver sulfadiazine to deep partial thickness burns. Alright, if the patient meets the criteria, admit them to the hospital and order labs, including CBC and CMP. You may identify electrolyte abnormalities, especially in larger burns with TBSA greater than 20%. When it comes to management, the main goal is fluid resuscitation. If your patient's TBSA is 10 to 20%, start maintenance lactated Ringer solution to maintain urine output at 0.5 milliliters per kilogram per hour. If the TBSA is greater than 20%, use the Parkland formula to determine your patient's fluid deficit. The Parkland formula is as follows: 4 milliliters multiplied by percent TBSA multiplied by the patient's weight in kilograms. This will give you the total amount of crystalloid fluid needed in the first 24 hours, with half of the volume administered in the first 8 hours and the remaining amount given over the next 16 hours. Then administer lactated Ringers to replace losses and maintain urine output at 0.5 milliliters per kilogram per hour. Remember that in patients with severe burns, exclusive use of crystalloid fluid may result in over-resuscitation, which can lead to complications like bowel and pulmonary edema. Next, you should initiate pain management with medications like acetaminophen, gabapentin, or narcotics. In intubated patients, you should also administer sedation. Now, always remember that burn patients are in a hypermetabolic state, meaning their bodies break down more protein. In terms of nutrition, burn patients have higher caloric and protein needs. If they can tolerate oral intake, start them on a high-protein diet. If they are intubated, initiate enteral nutrition and start prophylaxis to prevent stress ulcers. Here's a clinical pearl. Since burns are open wounds, be sure to monitor closely for signs of infection. For non-surgical management, topical antimicrobials like bacitracin, mupirocin, silver sulfadiazine, or mafenide can be applied prophylactically over the damaged skin, while the use of oral or IV antibiotics hasn't shown any proven benefit or improved outcomes. Additionally, if they are not up to date on their immunization, make sure to give them a vaccine or prophylaxis for tetanus. Alright, when it comes to surgical management, patients with partial thickness burns usually need wound debridement and sometimes skin grafting. Grafts for partial thickness burns include xenografts and synthetic dermal substitutes. Patients with full-thickness burns will often require a different type of graft called an autograft, which uses the patient's own skin. Allografts, or skin from cadavers, may be used temporarily for deeper burns that can't be immediately staged. Now, if your patient has a circumferential burn, you might need to perform an emergency escharotomy. This involves making an incision through the burnt skin to release the eschar and restore circulation to the area, or in the case of a circumferential chest burn, to allow for adequate ventilation. Finally, fourth-degree burns that extend down to the bone might require amputation of the involved limb. Alright, as a quick recap, burns are classified depending on depth into first, second, third, and fourth degree, and some burns might be accompanied by smoke inhalation, causing inhalation injury to the airways. Treatment is based on the type of burn and the TBSA involvement. First and superficial second-degree burns are treated non-surgically with dressing changes and topical agents. Deep second-degree burns involving over 10% TBSA, third-degree and fourth-degree burns should be managed as inpatients. Administer fluid resuscitation with crystalloid, pain management, and nutritional support. Surgical treatment involves xenografting, allografting, or autografting. In the case of fourth-degree burns, amputation may be necessary if the burn extends to the bone.
A burn is the damage that happens after something really hot, like a fire, hot water or steam, or even a hot object comes into contact with skin. But burn injuries can also be caused by extreme cold, electricity, some chemicals like strong acids, or radiation, like from the sun or medical treatments. Ultimately, burns cause damage and inflammation of the skin. The skin plays an important role in protecting underlying muscles, bones, ligaments, and internal organs, forming a barrier to infectious pathogens and preventing water loss from the body. Now, the skin is divided into 3 layers: the epidermis, dermis, and hypodermis. The epidermis forms the thin outermost layer of skin, and it's made up of several layers of keratinocytes, which make and secrete glycolipids, which help to prevent water from easily seeping into and out of the body. Underneath the epidermis is the thicker dermis layer that contains the nerves and blood vessels. But the dermis is divided into 2 layers, a thin papillary layer just below the epidermis and a deeper reticular layer. The papillary layer contains fibroblasts, which produce a connective tissue protein called collagen. The fibroblasts are arranged in finger-like projections called papillae, each of which contains blood vessels and nerve endings. Nerve endings found in this layer sense pain and fine touch, which allows you to feel something like a feather touching your arm. The reticular layer of the dermis is even thicker than the papillary layer. The collagen in the reticular layer is packed very tightly together, making it excellent tissue support. In addition, fibroblasts in the reticular layer secrete elastin, which is a stretchy protein that gives skin its flexibility. The reticular layer also contains the skin's accessory structures like oil and sweat glands, hair follicles, lymphatic vessels, and nerves, and all of the blood vessels that serve these tissues. A type of nerve ending found here detects pressure or vibration, which allows you to feel someone grabbing your arm. Finally, just below the reticular layer is the hypodermis. It's made of fat and connective tissue that insulates and pads the deeper tissue, and anchors the skin to the underlying muscle. When the skin is burned, it damages cells and the proteins within them, and the number of skin layers affected determines the burn degree. So, in first-degree burns, also called superficial burns, the burn only affects the epidermis. In second-degree burns, the burn affects the epidermis and the dermis. If only the papillary layer is burned, it's considered a second-degree superficial partial thickness burn. But if the burn reaches the deeper reticular layer but doesn't extend through the entire layer, then it's considered a second-degree deep partial thickness burn. In third-degree burns, also called full-thickness burns, the entire epidermis and dermis are affected. And finally, fourth-degree burns extend into the hypodermis. When a skin layer is affected, it means that the skin can't function effectively, and common complications are infections, especially from Pseudomonas aeruginosa, and water loss through the damaged skin. As burns heal, macrophages move into the tissue to remove dead cells, and fibroblasts create new collagen to heal the damaged skin. The more extensive the area with new collagen, the more extensive the scar. So, scars are common in second-degree deep partial thickness burns and third and fourth-degree burns. Symptoms of a burn depend on the degree of the burn. In first degree, the affected area becomes red, dry, and painful. These areas also tend to blanch, turning white as blood flow is restricted with compression. Second-degree superficial partial thickness burns can be red with clear blisters, wet as if they're weeping, and are even more painful than first-degree burns, but still blanch. A second-degree deep partial thickness burn may vary in color from yellow or white to red, have blisters, and can be wet or dry. Because of damage to blood vessels and nerve endings, burns of this degree may not blanch, and there may only be pain due to pressure because of nerve damage. A third-degree burn can appear waxy white to leathery gray or black, and dry. Again, blanching doesn't occur and the pain may only feel like deep pressure. In other words, they can be relatively painless. Additionally, the elastin damage causes the burn to be stiff or inelastic. Finally, fourth-degree burns are charred black, dry, have pain only from deep pressure, but can be painless from complete destruction of nerve endings, and have patches of dead skin. Having said that, the margins of all burns often have lots of damaged nerve endings, and that can be painful. The diagnosis of a burn is often based on the burn's appearance and the amount or type of pain. But sometimes tissue biopsies are obtained to accurately determine which layers are affected. In adults, the severity of burns is calculated using the rule of nines. The rule of nines evaluates several distinct sections of the body's total surface area for the presence and degree of burns. 11 of the sections each make up 9% of the body's surface area and are the head, right arm, left arm, chest, abdomen, upper back, lower back, the front of the left leg, and the back of the left leg, and the same for the right leg. A final section, the groin, accounts for the missing 1% of the body's surface area. The treatment for a burn is determined by what caused the burn, the rule of nines, and the location of the burns in the body. In general, immediate treatment typically includes preventing further burning, like flushing the burn with cool but not ice-cold running water. After that, it's important to manage pain with medication. Minor burns, like first and second degree superficial thickness burns, can heal on their own over a few days or weeks by keeping them bandaged and clean with soap and water. Sometimes lotions to prevent drying or topical antibiotics can be used. If blisters form, it's best to leave them alone, because the intact skin helps to prevent infections. For more serious burns, like electrical and chemical burns, or second or third degree burns in sensitive areas like the face, hands, and genitalia, hospitalization in specialized burn centers is often needed. In those situations, it's important to replenish lost fluids and electrolytes, and to prevent infections with antibiotics. Surgical procedures like skin grafting, excision of dead skin, or amputation, especially in third or fourth degree burns, may also be needed. So, to recap, a burn is injury, protein denaturation, and cellular damage that occurs in the skin caused by extreme heat or cold, electricity, some chemicals, or radiation. The degree of burn is determined by whether the epidermis, dermis, or hypodermis are affected, and each degree has specific symptoms. The rule of nines, the cause of the burn, and location of the burn can help determine treatments. In general, treatments include minimizing the initial burn and pain management. Minor burns don't typically require treatment beyond keeping the area clean, moist, and bandaged. But severe burns may require more extensive medical intervention, particularly hospitalization at specialized burn centers to prevent infections and dehydration.